You may begin your conference.
Thank you. Hello, everyone, and welcome. I'm Claire Thayer, Vice President, Business Development with MCOL, and I'll be your moderator. We're so very glad you could join us for today's presentation, What Your Data Knows That You Don't. Today's webinar is co-sponsored by LexisNexis Healthcare. Before we get started, we have just a couple of housekeeping items. Our speaker will be taking your questions via the chat feature, and while all questions will be addressed at the end of the presentation, you're more than welcome to send in your questions now at any time throughout the webinar. The chat box is located on the lower portion of your screen. Lastly, if you require any other assistance, please contact the Healthcare Web Summit office, and they may be reached at 209-577-4888. Kathy, we're ready for you to begin.
Great. Thanks, Claire. And thank you, everyone, for coming today to listen in. Some of this you may have seen before in other presentations, but I hope that it will give you some new and refreshing insights. My name is Kathy Mosbaugh. I lead the development of our healthcare analytics solutions at LexisNexis Risk. We focus on data aggregation, analysis, and predictive modeling to address a variety of healthcare challenges for improving care, reducing costs, and optimizing business performance for our healthcare clients. Just to get started, I want to highlight the key takeaways that I hope you learned today. And one is that as our healthcare market continues to evolve, it's going to require us to intelligently leverage big data to really achieve excellence in care. I also want you to know that consumer socioeconomic data is a new frontier that reveals unknown risks and can bring new insights and clarity, and that the consumer socioeconomic data that I'll discuss, when combined with other sources of data, can be highly valuable in driving individual and population insights. So to get started, I want to focus real quick on quality, because quality didn't come into play over the last several years to solve the problem that healthcare costs are rising. Quality became a focal point because avoidable healthcare costs exist. And it's this study that I've shown many times, and it's becoming a little bit dated, but it was published by IMS in 2013, and it estimated $213 billion in avoidable costs were incurred in 2012. And you can see a couple of the key drivers were non-adherence and delayed evidence-based treatment practices. So while I'm reading recent reports, and I'm sure you are as well, that demonstrate we're seeing slower growth rates out of some of these innovative initiatives and some of the ACOs, we really need to stay focused on the goal of improving quality, which includes reducing avoidable costs. The value, to me, is the right word for this concept of reducing avoidable costs and not simply reducing overall services. And fee-for-service, by design, allows avoidable costs to occur. It's blind to the complications, never events, and the causes for readmission. And so in our efforts to become more connected and transparent as a system, we've embraced technology, and we continue to strive to make quality as high a priority as cost reduction. And now we have these quality measures driving expectations and reimbursement strategies, and it has changed the game. So I always like to do sports analogies, and we were playing golf. You hit the ball down your fairway. I hit the ball down my fairway. Individually, but now we're playing a different game, and it looks more like hockey. It's fast, it's rigorous, and we're trying to play as a team. And in that type of new sporting environment, you have to adapt quickly. And for us in healthcare, we're adapting quickly within a system that's trying to increase data availability exponentially. So we've started to measure performance on these nascent data reserves with the best intentions, but there's much more we need to understand, and the data we rely on now becomes more critical to uncover not only the processes we use, but the people we serve and their individual needs. There are 319 million individuals in the U.S. There are about 35 million admissions to registered hospitals, nearly 126 million outpatient visits, and nearly 929 million physician office visits. So as we shift towards personalized medicine, how do we get a better understanding of the people that we need to serve and where they are? But besides sports analogies, I want to draw another analogy for you, which I have found very fascinating when I look at healthcare, big data and analytics in this evolution. It really starts with the telescope. And the telescope was central to what has been called the scientific revolution of the 17th century. And at the time, it revealed all of these phenomena in the heavens, and it had a profound influence on the controversy between the heliocentric system of Copernicus and geocentric astronomy. So it was the telescope that heavily influenced people to even buy into the idea that the Earth revolves around the sun. So the telescope, it provides its effect using several combinations of concave and convex lenses and mirrors. And some research suggests that the materials to create the telescope were available in the 15th century, but the telescope wasn't invented for another 150 years. I feel like our market's a little bit different from where we were in the 15th century, but the timing may be similar. The telescope was also very simple by its design, and it had a very limiting factor that it could only see a quarter of the moon. And what it did, though, was really pique the interest. And so over the next several decades, the viewing space, the desire to increase that viewing space, led to the marketplace of craftsmen who were developing and designing new ways to grind and polish the lenses to get a better lens for the telescope. Fast forward several centuries, and we see that allowing visibility into space, into the heavens, so to speak, allowed scientists to further question how and what could also be seen. And so most recently, the idea to move closer, you may think of it as putting ourselves into the very space we want to know better, we launched the Hubble Space Telescope in 1990. So what is the point of all of this, particularly when we see things like SpaceX and Elon Musk, which to me is the next evolution and generation and still seeing further beyond. But what this did for us is that gave us greater clarity. And so first let me show you a view of space from Earth before the Hubble Space Telescope. And here it is from Hubble. So putting the Hubble Space Telescope closer to its target revealed things that apparently were hidden, that we couldn't see previously. This also gave an indication of these things that we couldn't see because the colors indicate the intensity of those stars. So the blue are actually hotter. It could also help us with things that we knew were there. So this is an image of Saturn from a telescope on Earth. The Hubble Space Telescope certainly gives you greater clarity and crispness to what you know is there, but you just don't have a sharpened image. And really the point of all of that is that with a more complex and stronger telescope focused closer to its target, you have a more complete picture, a more interesting picture, something that you had not expected before, and things that you can start to work with and devise new ideas as well as concepts for where to go. And so how does that really apply to healthcare? Something that I carried over in this as well is that there's really two general features to the telescope, and that's the light and the lens. So you have to imagine analytics as our lens and data as our light into that lens. Our universe encompasses the patients, the consumers, the members that we're trying to see and understand for their future health risks and needs. Looking at the one piece with the analytics, it's incredibly important for good reason. So predicting human behavior is used across multiple industries for a variety of reasons: to combat financial risk, to conquer spam, to toughen crime fighting, to boost sales in some cases. And analytics has been leveraged even in healthcare for decades. But it doesn't mean that what we have is good enough, nor that everyone understands what analytics and predictive modeling is even trying to accomplish. Many analytics are focused on financial forecasting alone at a group level. But when you start to think about what we talked about at the beginning in reducing avoidable costs and quality, that game has changed, and what we need to find are avoidable costs. A predictive model is really positioned to give a greater degree of effectiveness because you can be proactive with your next step. The predictive model says what will happen next if nothing changes. And when you leverage a model or a predictive analytic, your next step is to make a change to avoid the unnecessary cost. Looking very briefly at the light that feeds into our lens to give us this better image, we have a picture of all of these different data sources that are or are becoming more available to a broader group of individuals in healthcare. And as I even put this up here, I can even add in device data, whether that's coming from a medical device or an activity tracker, right? So trying to keep the image as simple as possible, but knowing that the data sources are growing as they should in big data, right? There's the velocity of how this information changes, and there's also the variety of data that's coming in that we will be challenged with as an industry to try and capture and use in the best and most effective way. So each of these data sources can contribute value to a variety of use cases, and some of those use cases are represented in the boxes. But the level of value really depends on the target of any sort of analytic or prediction and the analytics themselves that are being developed. I've used this chart before. It's really just a representative chart, and I hope it spurs a conversation either at the end or separately about data and how it's valued and how it can be used. This chart was actually developed from some LexisNexis scientists who had been working with healthcare payer data. Just asked them to put together some experiential information. Just again, understand and illustrate what we're saying about the relative value of the different data sources. The medical and pharmacy claims, which have been used for decades by payers to understand costs, is available for the majority of members in a health plan. 80 to 90% will have claims data. New enrollees and non-users will not. And in most cases, you probably have to clean some of the data for gaps in data processing or collection. But overall, claims data is available in a very structured and standardized format, so the scientists considered it very reliable. It really became a benchmark to compare the other three categories on this chart. The lab results would be very beneficial to predicting future risk, but it's not always readily available to link easily with claims data. For ambulatory services and managing patients holistically, labs would paint a very narrow view on their own without claims or clinical data. And due to the lack of availability, just consider them to have limited potential to improve a risk prediction accuracy for today, considering where we are today. Health risk assessment data, I've seen this evolve quickly, and moving from enrollment surveys to engagement surveys to wellness surveys, but it's not readily available in a standard format in comparison to claims data. It could be extremely helpful as an early warning for potential risk of new enrollees. It could also tell something about missed or unknown diagnosis or family history or other lifestyle factors that may not be available anywhere else. So therefore, the belief is that it will have high value, but it will take some time to further refine as far as a standard data source across healthcare. Final category, and one that we could talk about from LexisNexis, was public and proprietary data that reveals socioeconomic influences. And it's this type of data that when I talked about the analytics being used to predict human behavior, but this type of data is used also to fight crime, locate missing people, and assess risk, right? It's one of the data sources that feeds into a lens for a variety of use cases. Its use has been limited in healthcare, even though there's definitely a greater interest in it, even in the last 12 months. There is a relatively large amount of data available on individuals, and the data is reliable in its format and structure. So its potential to improve the accuracy of predicting risk and revealing hidden unknown trends is high. So I talked about this being a representation of working with payer data, but I feel like I need to mention EMR data, which is rapidly becoming available and more standardized. Linking that data to more longitudinal data on an individual is the challenge. And when I personally look at EMR data in comparison to claims data, it looks like the opposite of one another. So when you have opposites, you could probably combine those and get a bigger picture. But the scope of data is different from claims data to EMR data. The scope of patients that are covered is different, and the richness of the data is different. So as this continues to evolve in EMR data, I'm certain they will we'll gain significant insights as it's more easily linked and as we increase our connectivity across healthcare and these data sources. So I just want to take a few minutes because we talked about the light and lens concept and how it relates to analytics and data in healthcare. But now I want to take a step back and look at driving the need for alternative light sources, alternative data sources, how you want to look at that. And it's really the big picture driving the need for socioeconomic data. So regulatory changes with the Affordable Care Act may be evaluated with the recent election, but the reality is that healthcare costs continue to increase, and there are only so many staff resources available to manage health plan member populations and consumer needs. So the need to manage the costs and focus staff on the right people requires a deeper and more holistic view of a person. The data that we discussed in the previous slides, it all has limitations, and therefore many forces are acting to drive this need for more data. And I do want to stress that there's really no silver bullet today, and it's really the combination of multiple data sources and approaches that's going to get us to better answers. So how can socioeconomic data help us determine someone's risk in healthcare? There are many paths and many important criteria and targets to consider. The slide that you see quickly presents behaviors such as ER visits and medication adherence, as well as conditions such as depression and anxiety that are influenced by an individual's socioeconomic environment. Intertwined with these conditions and behaviors is stress. And the stress and socioeconomic influences such as financial concerns also impact how a person interacts with the healthcare system and how they are able to engage in their own care. 28% of those surveyed said that stress had a strong impact on their mental health, and 20% of Americans surveyed said they skipped going to the doctor due to financial concerns. These type of social pressures and decisions contribute to a cycle that perpetuates increasing, and I'd like to point out, avoidable healthcare costs. If we remember, the study shows that one of the biggest drivers for avoidable healthcare costs was non-adherence. So you look at poor medication adherence, which is believed to be influenced by socioeconomic factors. If you don't take necessary medication, then you can expect an exacerbation of poor health outcomes, leading to more service utilization, higher healthcare costs, and higher premiums and copays. So what do we mean by socioeconomic indicators? Historically, socioeconomic data meant income and education. However, it encompasses so much more about an individual. Social determinants of health is also a term that's used often in the industry to talk about different types of influences on an individual outside of their medical history. It's really through the results of data aggregation, big data processing, and proprietary linking that my company, LexisNexis, is able to deliver results from a very large pool of data, over 2 petabytes of data on 250 million uniquely identified individuals. The information, it helps, I've mentioned this a couple of times, but it helps locate and identify people. It can provide information from addresses to phone numbers, birth dates, vehicle-based registrations, and similar data has been used to support a variety of needs in other markets, from finding deadbeat dads to preventing identity theft to preventing fraud in general to supporting pricing policies and auto insurance. So we know this data is there, it's available, it's been used successfully. So what does this mean for healthcare? You could locate people better for one, and just being able to find people can have a big advantage. But there's much more the data can tell us when linked to a person's medical history. Many research articles have looked at disparities in healthcare outcomes of socioeconomic status. And the socioeconomic status is relating to a person's occupation and education. But again, there was more in the data that can reveal environmental and community influences. With analytics, the data can be transformed to offer even deeper insights about a person's needs or their risks. So using big data, hospitals can better understand a patient's risk for poor outcomes that may lead to readmissions. Health plans can look at it to assess risk for someone that don't have any medical or pharmacy claims background to what could be their potential costs in the next 12 months. And it's really this whole area that's a new frontier. And it's as this data becomes more accessible and leveraged to improve care that we'll be able to see needs more clearly and be able to ask better questions of how we improve the system of care overall. I know there's going to be some questions about the data, where it comes from. I think it's come for us, the data is pulled from over 10,000 data sources. What we leverage includes 42 million more individuals than you'd find in many other data sources. We have 4 billion property records, 417 million criminal records. So it's a very large set of data that has been leveraged. And what we've done, when we talk about socioeconomic health attributes, is if you've got this data on individuals, how do we know that it is valuable to assessing somebody's risk and to revealing what may be unknown risks that we could take action upon? And that required that we think about healthcare targets that are important. So like cost and hospitalization and emergency visits, right, on a scale, how likely is somebody to adhere to their medication, how motivated are they, as well as binary outcomes. Did they go to the emergency room? Did they have higher costs than somebody else? And so looking at these targets and outcomes, we started to look at the data to derive a variety of attributes, looking at greater than 384 socioeconomic attributes across a variety of different healthcare outcomes. And I wanted to share just a couple of the insights. It could go on, but some of these just to kind of get your mind thinking about information that may be important and how it could be integrated into some of the ways you're trying to work with your clients or your members and help them assess their risk. One example is looking at incidents of crime in a neighborhood. So based on different categories in a given zip code, we can find that there is a correlation between crime and a person's likelihood to adhere to their medication. So if they live in a neighborhood with a higher crime index, then they are less likely to adhere with their medication. We also observed that the higher your income, the less likely you are to utilize the ER. Now, these are very simple examples, and they may seem obvious or feel like common sense, but understanding this type of information in a digital form and incorporating it into analytics or into a workflow system at the time that you're interacting with an individual is a completely different scenario, right? We may know this to be logical, but how do we actually put it into practice? We also observed, and it's not in a chart, but we also observed that change in income is also an important consideration when you want to think about how you support an individual or assess their risk. If an individual makes $100,000 today, it's very important to understand that if they made $50,000 yesterday is much different than if they made $300,000 yesterday. So understanding the trend as to whether that's increasing or decreasing can also have an influence on the individual's ability to engage in their own health care and their health outcomes. We also worked with EMR data for discharges to evaluate public records data in relation to readmissions. And in this one case, how often and when you move may make a difference in your risk for hospital readmissions. In this case, if you're over 50, admitted to a hospital and recently moved, there's a slightly higher risk. Another interesting event in a person's life that implies a recent move and financial stress is an eviction. We observed a higher rate of readmissions for a population under 50 with a higher rate of evictions. And there were many more correlations, some strong, some weak, some data elements that don't correlate. In some cases, number of accidents, number of bankruptcies, or whether you had professional alliances did not indicate whether you were at higher or lower risk. I point that out because I've had many conversations with a variety of groups about using different data sources that say they didn't get any value of that, and I see why that's the case. Not all data is created equal. While the individual data points were evaluated, we find that the combination of multiple data points, whether that's all coming from a socioeconomic perspective or it's combined with claims, is really how you get the best insight into predicting the target that you're focused on. We did work with one client that I wanted to highlight just as an example as somebody moving ahead to try and improve the way they deliver care and how they engage with their members. Every Move offers a engagement platform. They help their clients identify, stratify, and assess risk in a population. And they have started to leverage new data sources such as socioeconomic data in their efforts to identify members to help allocate resources as well as intervention strategies. And they were finding that in adding the additional socioeconomic information and the socioeconomic health score, that members in the top 10% of the score had significantly higher risk than average, and the bottom 10% had significantly lower risk than the average. We really start to look ahead to where this can get us beyond improving the immediate care of the patient and improving the way we can implement strategies and execute on care plans for individuals. The opportunity exists to even risk adjust for socioeconomic status, allowing appropriate allocation of resources and reducing risk when caring for even the most vulnerable populations. And it's when you're able to make data, such as what we've been discussing today, available in a way that's easily digested and then transformed into a different insight or a different answer about an individual, that we start to move in this direction, and I think starts moving us closer to where we want to be, more around the value-based discussion and less around the fee-for-service. How do we reduce avoidable costs and get the most value out of the system and not just reduce services? One of the things to talk about when we look to the future that I wanted to share, and it's again a point where I appreciate the conversations and the feedback, but these are critical aspects to successfully leveraging new types of data and analytics in healthcare. When we talk about contextual data, I've mentioned it before, more data I believe is better, but not all data is created equal. So we're striving to look at data more closely, to validate that, to look at a variety of targets and outcomes, and understand, does it have a positive correlation? Does it have a negative correlation? Does it not contribute at all? We also want to have relevant insights, right? You want to understand, does this apply to what I'm trying to achieve? Looking at somebody's total forecasted cost in the next 12 months is much different from understanding if someone's going to be readmitted to the hospital in 30 days, which again is different from will they engage and go to their doctor for a follow-up appointment. What type of influences act in each of those scenarios, and how can you capture that in an electronic or digital form to be able to apply it and then make it actionable? And that really leads into the enhanced analytics with seamless integration. Successfully utilizing new data and analytics is really where we want to end up, but it's going to take incremental steps to get there. As new systems come into place, as new teams and resources and skill sets come into the market, there's also going to be the need to better understand the data sources that can feed into all of that to come up with better answers. So in summary, I'm going to go back to what I had mentioned at the beginning, and these are just the key takeaways. that I hope you have heard and understand and agree with, which is that we have to intelligently leverage big data in healthcare, and we're making great strides in that direction, but it's not an end game. It will continue to grow and change and evolve. Socioeconomic data is really a new frontier that reveals unknown risk and can bring greater clarity and refinement to a lot of the targets that we're trying to understand. And it's really when you take this consumer and socioeconomic data and combine it with other sources of data that it can be highly valuable in driving individual and population insights. I want to thank all of you. Appreciate you taking the time to listen in and learn what we wanted to share today. I've got a look at the questions that we will do before we close out. My contact information is available on the screen if you want to take that, and feel free to reach out to me with any questions or comments. One question that I received is LexisNexis creating a profile for each unique individual proactively or upon query by an EMR. At LexisNexis, we have a variety of data sources that come in that I had mentioned before, and we have a set of proprietary algorithms that can link the records to an individual. And so in that way, we are able to have a profile of an individual that can then be leveraged in the potential way that they need to use the data. So if you have an individual and you want to improve your care management strategies and you need to understand information, we can pull that data together on an individual, weight it, and determine what is their potential socioeconomic health risks for based on where they live and other types of demographic data that we can pull together on that individual. So we are proactively pulling that together. It doesn't preclude an EMR from creating their own profile. We are able to augment profiles, whether that's with contact information to help locate an individual and reach out to them, which is a big part of engagement, and also improving health outcomes. Another question, is Ellen creating a profile of the healthcare system population overall? We can provide information on the population. We work with partners or whichever systems that you may have to take that information in and combine it and aggregate it with other data sources. I know some questions are coming in about the PowerPoint, which will be made available to the participants. Okay, I think that's going to be it for our questions today. Again, I thank you for your time. Very much appreciate your interest, and I look forward to future events and having you attend. Thank you very much. Claire, I'll turn it over to you.
Okay, great. Thanks, Kathy. And this is Claire back on the line. At this time, we'd like to thank you, Kathy, once again, and we'd also like to thank our webinar co-sponsor, LexisNexis Healthcare, and all of the registrants who were able to join us today. We will be sending a follow-up post-event feedback email and would love to receive any feedback you wish to share at that time. And that's also another opportunity to submit questions for Kathy. Note that the email will include a link to the webinar recording along with contact details should you wish to receive a copy of the PDF version of the slides. If you haven't already done so, we encourage you to join our LinkedIn group on the web where you can post additional questions or start discussions and even suggest topics for future webinar events. And with that, have a good afternoon. This now concludes our webinar.